Hello, everybody, and welcome. Can I just confirm that everyone can hear me okay? Look for a thumbs up. All good.
Yep.
Great. Let's get into it. Hi, everyone. Thank you for joining us from wherever you are in the world. Today, we are super excited to be welcoming five civil society leaders to discuss what they have learned from CCAE's very first HPV vaccination learning series and how they are applying what they've learned into their own communities. My name is Isla Colley. I'm a senior policy, advocacy and programs advisor here at CRUK, Cancer Research UK. CRUK co-chairs the Cervical Cancer Action for Elimination, that's CCAE, with the American Cancer Society. Now, our collective goal through CCAE is to bring CSOs together to accelerate global progress towards a world free from cervical cancer. Please do share your name, your organization, and your country in the chat so that we can see who we have in the audience today. Just a reminder that following our presentations, we do have a Q&A. So as you listen to our brilliant speakers, please do use the Q&A chat or chat function to ask your questions, and we will get to those after our presentations. So I think we've got a poll that should be popping up on your screen soon. This is for us to get a quick snapshot of your experience in the HPV vaccination space. Give you a minute or two to answer that. Great, can see some responses coming through. Please do keep them coming. Brilliant. Thanks, everyone. That's great to see. So I just want to start off by giving you a little bit of context about the CCAE learning series. So we know that CSOs globally play a critical role in advancing HPV vaccination and cervical cancer prevention, all the way from community engagement to advocacy, and of course, implementation. So our aim through the CCAE learning series was to strengthen the capacity of civil society organizations in low and middle income countries with the knowledge, the skills, and the tools to integrate behavioral science insights into their efforts to promote HPV vaccination as a key strategy of cervical cancer prevention. So the learning series comprised of several phases. I think I did mention this is the first time that we've done this series, so definitely a bit of learning as we go. The first phase was a 4-day learning sprint, which was in September last year. That included presentations from global experts and our CCAE faculty, I think a few of whom are on the call today. After the sprint, the cohort met every other week for 6 90-minute technical assistance sessions, and those wrapped up in December. So in total, our amazing learning series cohort engaged 19 hours of learning in the virtual classroom, and many more hours applying what they learnt in their own work and in their own communities. So we're now up to the third phase of this process, which is our showcase webinars, which are very exciting. This is the second of 3 showcase webinars where participants are able to present their case studies. Over all 3 of the spotlight sessions, we're going to be hearing from 13 cohort members who will be presenting their findings. Finally, as the series wrapped up, everyone who completed the series was asked to pull together a project plan and a budget, and they were eligible to apply for a small grant or seek outside funding to mobilize resources to actually implement the project that they developed. So it's been a super exciting process, and we've loved meeting all of the amazing people and organizations who we've had in this cohort. You can see a few pictures on the screen there. So we had 56 leaders in total in this cohort, and they represented 29 organizations across 17 countries. So that's a pretty amazing turnout. All of them are working towards one shared goal, which was to eliminate cervical cancer. The cohort was supported in their learning from international experts, including our 8 amazing faculty members who you can see on your screen there. As a result of the series, we saw 7 types of target audiences being identified. Can see those on the screen there. We had 9 types of behavioral problems identified. We had 56 behavior change solutions that were designed, and we had 14 evidence-informed projects that were developed as a result. So it's been a pretty amazing journey. If you tuned in last week, excuse me, you would have heard from 4 of our cohort members from Uganda, Egypt, Malawi, and Pakistan. If you did miss that session, you can watch the recording, which we will post a link to in the chat. So keep an eye on that. It was a really amazing session. I would encourage you to tune in if you haven't seen it already. Today, you're going to be hearing from another 5 of our cohort members from Uganda, Nigeria, Kenya, and India, I think. Yes, there we go. We've got them all on the screen there. As I said, we will have a Q&A panel at the end of the presentation, so please do think of questions that you want to ask your speakers, and you can put them in the Q&A box. Or if you can't get that out, please do put them in the chat. Just to confirm that we will be recording today's session and we will give you a PDF of the slides. So, having said all of that, I would like to introduce you to our first speaker, Gertrude Nachigude. Gertrude is the Chief Executive Officer of the Uganda Women's Cancer Support Organization. She is a breast cancer survivor of 24 years. She's developed cancer advocacy, awareness campaigns, and patient support programs for the last 20 years. She mobilizes partners and builds capacity for women who survived cancer and health advocates to educate communities, share testimonies, and provide hope to cancer patients and families to cope and adhere to their treatment. She's taken the lead in developing innovative programs and strategies for community engagement for cancer prevention and control in Uganda to enable access to HPV vaccination, timely, affordable, and equitable cancer services for the population. And she is also a member of ACHA, the African Cervical Health Alliance. So I'm going to pass over to you, Gertrude.
Thank you very much for the beautiful introduction. I cannot repeat that. And I'm happy to be part of this learning series. My case study is, we are talking about, our topic is breaking the silence, empowering teachers to lead the way in HPV vaccination advocacy in Uganda. Next slide, please. But I will ask to take off my video because of the internet interruptions so that I can stay online throughout the session. Thank you. Next slide, please. During the learning series, we learned how to diagnose and identify the slide before, please, the public health problem. My project will be addressing the low uptake of HPV vaccination among girls in Uganda as a public health problem. And to give you a bit of the highlights of our HPV vaccination in Uganda, HPV uptake is below 90% of the national strategy, putting many girls at risk of cervical cancer. The target is 10-year-old girls. HPV vaccination is free of charge in both government and private facilities. In Uganda, the vaccination is delivered through school-based program, outreaches, and out of school in static health facilities. We have a catch-up policy during the Integrated Child Health Days during May and October. Next, please. Having seen our public health problem, we needed to look at the behavioral problem that is contributing to the public health problem. And our behavioral problem is, before maybe I tell you that the audience we are targeting is the teachers. having learned that some of the HPV vaccination is delivered through a school-based program, we chose to target teachers, and teachers do not encourage parents to take their 10-year-old daughters for HPV vaccination. And this project wants to empower teachers to encourage parents to take their 10-year-old daughters for HPV vaccination. Next, please. We also needed to understand the barriers why teachers don't talk or don't encourage parents to take their girls' HPV vaccination. Teachers are not confident to talk about HPV vaccination. Teachers think it is not part of their work, and it is the work of health workers. And teachers think they don't have enough time to talk about HPV vaccination. We identified these barriers through our interactions during the learning series. We went out to interface with our targeted audience, and we interviewed teachers in private schools, in government schools, and also we compared the answers from the teachers in the urban schools and the rural schools. And we confirmed that these are the major barriers that affect or hinder them to talk about HPV vaccination to parents. Next, please. So still in the learning series, we went out to look for the solutions. How can we address the barriers that we confirmed and when we talk to the teachers? We are planning to conduct sensitization workshops on facts about HPV vaccination, availability of vaccines, and the importance of HPV vaccination in cervical cancer prevention. Some of the teachers are not confident because they don't have all this information. So it's important that we sensitize them. We also train teachers on how to deliver HPV vaccination information among parents, also to deliver it among other teachers and their communities. These trainings, we mentor teachers into HPV vaccination champions. So we feel these teachers can be champions given that they have enough time and the parents believe in the teachers, children and the students believe in teachers. So we believe once they are well equipped with the information, they can deliver the information about HPV vaccination. We also develop easy to understand messages and materials to help teachers easily deliver information about HPV vaccination. And all this will be intended to build confidence for the teachers, provide evidence-based information, and they give trusted sources for this information to help them be our champions, and they feel empowered and confident to deliver information about HPV vaccination. Next slide, please. We cannot do this alone. We have to have partners to be able to empower these teachers. First of all, our main partner is the Ministry of Health through the Uganda National Expanded Program on Immunization, UNEP, because it's responsible for the vaccines in the country. We shall work with the districts, the health department, and also we shall work with the health education department, because schools report to all are responsible through the education department in districts. We shall also partner with the school administration and the other civil societies. In this project, we target 2 districts, Kampala as a city, as an urban district, and Wakiso as a rural or semi-urban, because during the interactions with our teachers, we interacted with the 2 districts, and we intended to have 5 schools in each district. Next, please. During the learning series and then during this exercise, what have we learned? It was important for us to learn that teachers are such an audience that has not been really targeted in in HPV vaccination, but we have a strategy that goes through schools, as we've had the teachers think it's not part of their role. So they didn't see any connection between their work and HPV vaccination and the cancer in general. So because they always thought the health issues are handled by health workers. This was very important as an opportunity for us as we design programs to bring everyone on board, especially people who interact with the audiences or the people that want to benefit from our programs. We also learned that teachers had a lot of negative stories on HPV vaccination, and we believe empowering them and giving them the information they need, we shall have increased uptake of HPV vaccination. We also learned that HPV vaccination uptake is still a global challenge. We thought it was a Uganda problem, but during the interactions with the colleagues during the learning series, we learned that many countries are still struggling with this low uptake of HPV vaccination as a public health problem. Also, we learned that bringing countries together for this series bring different perspectives. It was a lot of learning from other partners, from other countries, and also from the organizations that are within our countries. This brought us together, and we intend to work together to have better results. Next slide, please. Next steps, what do we intend to do after all this wealth of information and knowledge that we received through the learning series? Integration of behavior science into our existing program. It was so exciting to learn that behavior affects many other parts of our programming, and once we don't include behavior science, we may not succeed in what we are planning to do. We intend to engage partners and seek funding to ensure that our lovely projects are funded and implemented. We also want to pilot this designed project in a neighboring school. My office is near a school, a public school, where we can pilot it. I think it will be low cost, so that we see whether our interventions can work and which we can scale up to other schools. We shall continue engaging organizations which have been part of this learning series to continue learning from each other and sharing knowledge and experiences, especially with the projects that many people have showcased today and previously, and then in the next session. Next, please. You can learn more about us. These are our social media connections. So we'll be happy to hear from you and quickly interacting with you. Thank you so much for the opportunity to be part of this learning series and also to showcase our project and our efforts in HPV vaccination in Uganda. Thank you so much. Back to you.
Thank you, Gertrude, for that brilliant presentation. And just a reminder to our audience to please pop any questions you might have for Gertrude or our future speakers into the chat, and we will circle back to them for our Q&A later on. So next up, we've got Mr. Nifa Butu. Mr. Butu is a monitoring and evaluation professional at Save the Slum Initiative, where he leads data collection, analysis, and learning to strengthen program effectiveness and accountability. He supports evidence-based decision-making, reporting, and performance tracking across health and community-focused interventions. So I will hand over to you.
Okay, good afternoon, everybody. Thank you for that introduction. I hope I'm loud and clear. So from the CCA learning series, our project is going to be talking about the intake of vaccine. So it's a behavioral design model to increase HPV vaccination intake. And like you rightly said, my name is Nifa Butu. So our public health problem is that generally in Nigeria will have the highest burden for cervical cancer and a disease that is almost entirely preventable. So over 12,000 new cases and 7,000 plus death rates from cervical cancer occurs annually in Nigeria. And despite the availability of HPV vaccine, fewer than 9% of eligible women access screening. 80% of those cases are diagnosed at advanced and costly stages. So the root cause is that the low vaccination rate is driven by vaccine hesitancy, widespread misinformation, and inadequate healthcare infrastructures in some locations. So our desired outcome is to overcome vaccine hesitancy and to reach the national HPV vaccination targets for girls aged 9 to 14, thereby preventing future cervical cancer cases. The next slide, please. So behavioral problem is that parents do not take their daughters aged 9 to 14 to health facilities. So parents of girls aged 9 to 14 need to stop delaying and avoiding the vaccine decision action and start taking their daughters to facilities. So our case study will be on the parents, right? So next slide. So the barriers we encountered during the learning session was misinformation and fear. So beliefs, because we're in the northern part of Nigeria, Maiduguri, Borno State, and the cultural sensitivity here is really, really something we need to break through. So misinformation and fear, believe that the HPV vaccine causes infertility or other severe side effects because most of the parents here are illiterate. They are not educated in the formal system. So stigma and shame associated with the vaccine, with sexual activities leading to fear of community judgment. So anything that has to do with people looking at your family like you have immoral children and stuff like that, everybody avoid it by all costs. So present bias, prioritizing immediate need, which is school fees, work, food, over long-term health prevention is also a barrier we faced, and loss aversion, overemphasizing potential risks, the side effects. They've not done the test, they don't know who have gone through the vaccination, but they just assume there are going to be side effects and they emphasize on the side effects more than the future benefits of preventing cancer. Information overload. So because most of them are illiterate in this context, if you come to them using bogus languages, big terminologies, talking about HPV, many of them have never heard about HPV. So you have to break the languages you use. So when you come overwhelming medical terminologies and information leads to just information overload and they just shut down when you are talking. So low perceived risks. So people believe in this part that the the cancer, the cervical cancer, it's not really something that happens to everybody because they feel it's one in a thousand, or probably people that are involved in immoral acts, people that are just not. Hello? Yeah, so that's why they perceive there's a low risk to their children having cervical cancer. So they just, I'll just slide on this. So financial constraints, most times because of the lack of health facilities in rural areas, many of them tend to not go to the facilities because many of them give birth at home. They take medical advice from mothers, from grandmothers, and from husbands. So if there's no need to go to the hospital, sometimes they just use the cost of transportation as an excuse because most of the things they learn they use from the past, their parents and the society. So time constraint, inability to take time off work and from their farms, because most of them in this region go to farm, especially during the farming season, and during the dry season, they also engage in irrigation farming, right? So the solutions we came to during the series is that we'll create short videos featuring local doctors, religious leaders, because they have influence over the parents. Because no matter what you do, if the parents are not willing, you can talk and talk and they will not still take the children because they have the final say. And sometimes the mothers also have to take permission from the grandmothers, the mother-in-laws, even the husbands before they can go into take their children for vaccination. So also educates the videos covering even mothers of vaccinated children, girls, so that they can debunk the infertility rumors and address misinformation. Also campaign slogans like protect your child today and prevent cancer tomorrow, tagging the HPV awareness as a cancer prevention and not something else, because all of them know about cancer. They don't just know the type of cancer. So once you tell them it prevents them from cancer, they would be willing and many of them showed interest in taking the vaccination. So we offer a health day package. Example like maybe a high blood pressure check for the parents that will bring the child to the hospital so that they can have something like an immediate benefit too. And it would encourage them to come to the hospital. So they don't just come because of the child alone, they also come for their own health to just do a little check on their own health. So to share testimonials from cervical cancer survivors or families affected by preventable loss to discourage loss aversion, where parents overemphasize potential risks over future benefits. We also use community board, billboards, and graphics materials to visualize our message in its simplest form and in local languages to avoid overload of information. Also, we train religious leaders. We will train religious leaders and traditional leaders because many of the parents here, or let's say in the northeastern context, we are very religious. So religious leaders also have influence over parents. So talking to them, also training them about the vaccine advocacy would also help them to mobilize and educate other members of the community as part of our sustainability plan. Also encourage male community leaders to publicly support vaccination because if the husband say, don't take my child to the hospital, the wife would not take the child, right? Even though it is the best for the wife and the child, and if the husband is not in the picture, he can still stop it, even when the mother wants to take the child to the hospital. Next slide, please. So the key partners were in partnership with the public healthcare centers in Maiduguri, because we've been operating here for a while and we've done something in the Northeast. So the council in Maiduguri, LGA, and also Konduga LGA in Borno State. We also have our community-based leadership council in Borno State, and we're also in partnership with the local school authorities in targeted communities because we also have some education projects we do here, and also the Ministry of Health in Borno State, and also the state's primary health care and development agency, also UNICEF Nigeria, Borno's field office, and Gavi CSU constituency. Next slide. So from the sessions we've had, the lessons learned was that providing facts about vaccine safety and efficacy does not automatically lead to action. So you can bring all your facts, it does not mean the parents will take action in taking their children to the hospital for the vaccine intake. So a trusted messenger delivering a simple message is more efficient and effective than an expert delivering a complex one. So that's why we want to train the religious leaders because they trust the leaders, train the traditional leaders also, and also train the parents, the grandmothers, the mothers, even the husbands, because they are trusted leaders and messengers and can be used to deliver effectively. So making the desired behavior easy is often more impactful than making it important. So instead of overemphasizing on the importance of these things, we try to make this desensitization and the awareness very easy and simple, right? Health issues linked with taboo topics like sex requires careful framing. And that's why we're not really putting it because many of them feel once you hear one or two and they say it is for immoral families or immoral girls, so they automatically segregate and say, no, my daughter is not this, she's too young for this, so she does not have a risk attached to this. So we reframe topics to avoid activating any shame or judgment, right? More moral and cultural associations can override so the barriers varies from community, gender, age, and socioeconomic status. So next slide, please. To the next steps, we'll add behavioral indicators to our MIE framework. We'll train staff on behavioral barriers, integrate into existing project programs. We also would seek funding to implement what we have learned in future projects. Next slide. So to know more about us, we're on social media and our handle is Save the Slum and our website is savetheslum.org.ng. Thank you very much for listening.
Great. Thank you so much, Mr. Butu, for that excellent presentation. So next up, I'll go to our next speaker. we have Dr. Kudus Lawal. Dr. Lawal is a gynecologist and program leader working at the forefront of cervical cancer elimination in Nigeria. He has extensive experience in HPV vaccination, screening, and strengthening health systems, with a strong focus on translating evidence into national policy and practice. Dr. Lawal has led and supported multi-stakeholder initiatives aimed at improving cancer prevention and workforce capacity across Nigeria. He currently serves as the Executive Director of End Cervical Cancer Nigeria Initiative. Over to you, Dr. Lawal.
Thank you very much, Isla, for that introduction. And good afternoon, everyone. As I've been introduced, I'm Dr. Kudus Lawal, the Executive Director of End Cervical Cancer Nigeria Initiative. And I'll be picking up from where Gertrude and Nifa have presented. They've talked about teachers and parents in improving HPV vaccine uptake. But for us, we are focused on another key stakeholder, which are the healthcare workers, as catalytic enabler of HPV vaccine uptake in the country. Next slide. So for us at End Cervical Cancer Nigeria Initiative, we have an overarching goal of ensuring that Nigeria is on the pathway to achieving cervical cancer elimination target as defined by the World Health Organization. And one of the key pillars, and indeed the most important pillars in our intervention, is ensuring that HPV vaccine uptake is achieved, having known that HPV vaccine is the most critical intervention to ensure that cervical cancer elimination is met. So we focus on ensuring, partnering with government intervention to ensure that it reaches the population that require it. Next slide. So we all know the story about Nigeria introducing HPV vaccine a couple of years ago and the good uptake we achieved during the rollout of the program. But unfortunately, the numbers are dropping. So there is a poor HPV vaccine uptake among adolescent girls in Nigeria. This is a public health problem, and if it's not addressed, we're going to have issues with achieving the elimination targets. So we look into this public health problem, looking at it critically and trying to assess how can we address this problem. Next slide. We know very well that most public health problems have contextual issues, structural barriers, as well as behavioral barriers. And looking at the behavioral barriers that affects HPV vaccine uptake, one of the key elements is the role of healthcare providers. So we notice that healthcare providers are not recommending HPV vaccine to mothers and girl child during hospital visits. We all know that the first contact, or the only contact most girls and mothers have with the healthcare facility, is when they visit hospital. That's when they have access to information about health. And if they don't get access to that information at that point, then this may be a major barrier for them having information about the value of the vaccine and the need to have it. So we see this as a low-hanging fruit, and we felt that it's something we need to address. So our target population is the healthcare provider, and the actions we need them to take is recommending HPV vaccine. So that speaks to the behavioral problem we try to address. Next slide. So we dig deep into the problem, the behavioral problem that I've identified, and try to identify the barriers by diagnosing what the issues are, critically assessing different factors that may play a role in the healthcare providers not recommending HPV vaccine. We did a diagnosis, reaching out to healthcare providers, asking them questions about their recommendation pattern and what affects this recommendation. And we identified some barriers, which are behavioral barriers that we felt are important to be addressed. One of which is that healthcare workers are not motivated enough to discuss HPV vaccine during clinic visits. Some healthcare workers also feel that they don't have that self-efficacy to discuss HPV vaccine during visits, especially with the profound myths around the community. So they don't get to speak about it. And also, some healthcare providers do not perceive cervical cancer prevention as a priority during clinic visits. So they don't get to discuss it, given other competing health needs of this of the healthcare provider to discuss with the patient. So cervical cancer prevention information is not the priority at those visits. Next slide. So we identified that if these barriers continue to exist, then we're going to have a challenge in achieving the emission targets we desire in the country. And therefore, we set out some solutions which are we critically analyzed and selected some of them which we think will be very impactful. One of which is that we plan to have sensitization workshop targeting healthcare providers in 6 geopolitical zones of the country. The country is a large country and has 6 geopolitical zones, and we identified a facility within each geopolitical zone. These facilities are going to serve as model. By the time we implement in this facility, then we're going to scale it up to other facilities within the country and use it as a model on how to improve healthcare providers' intervention. So during this sensitization, we're going to be discussing about HPV communication, providing them with short videos on importance of HPV vaccine and how they can communicate the vaccine. We're also going to be providing them with paper-based prompts and wall flyers, which will have information about how to communicate HPV, how to communicate to patients on HPV vaccine, and also create a social norm around HPV communication, making it a norm for health workers to provide information on HPV to patients. These flyers we're going to be making are going to be such that they're going to also have WhatsApp and the QR codes so that patients and any other person in the environment can easily reach out to us if they need further information about the HPV vaccine, and we'll communicate with them appropriately. Next slide. We also noticed that though there are IEC materials already in the community generally, but we want to develop an IEC material that's going to be co-designed by the healthcare provider themselves, as well as involving the community in such a way that the IEC materials is going to communicate to the particular community where is going to be culturally appropriate for the community where the information is going to be used, so that it's not going to be a one fit all. It's going to be designed for the particular geopolitical zone in such a way that is culturally appropriate. Then we realized that there is the importance of having nudge to ensure that people take action. Little nudge can make people take action. And one of such nudge is to have a commitment device, such as handbands, shared tags that has the inscription, "Ask me about HPV vaccine." The importance of this is that with this tag, even when the healthcare providers did not initiate the conversation about HPV vaccine, a inquisitive young girl or mother is likely going to read it out, and that will prompt conversation around HPV vaccine and therefore help us increase the uptake of HPV vaccine. So these are, next slide. So these are the interventions we intend to implement, and we hope that it's going to help improve the HPV vaccine uptake. But we're not going to do this alone. We have stakeholders in the country that are going to be collaborating with, who are actively working within this field. One of which is the Pediatric Association of Nigeria, who work with pediatrics patients. We're going to be working with the Nigeria Task Force on Cervical Cancer Elimination, who have statutory role in ensuring that cervical cancer elimination targets is achieved. The National Primary Healthcare Development Agency, who is responsible primarily for vaccination, are going to be a critical part of this. Nigerian Cancer Society, the Nigerian Medical Association, as well as the nurses organization are going to be working together with us to implement this project. Next slide. One key thing that we learned from this learning from the learning series is that there is generally lack of self-efficacy in communicating HPV vaccine amongst healthcare providers. It will be assumed that based on the fact that healthcare providers have knowledge about HPV vaccine, it will be easy for them to communicate this to patients and help improve, but that is not the reality. So it's not enough to have information. You also need to be able to build your capacity to communicate appropriately. Next slide. So taking it forward, the next steps, as I've highlighted, we are key on collaborating. We need to bring everybody together to the table to ensure that the upscale of HPV vaccine, especially what we achieved at the initial rollout is sustained. And with that, we expect that Nigeria will be on the pathway to achieving cervical cancer elimination in the next century by achieving the 2030 target of the WHO. Thank you very much. Thank you. So you can reach us through these various links. We are on LinkedIn, Instagram, Twitter, and also have our website, which can easily be accessed. Thank you very much.
Thank you very much, Dr. Lawal. That was great to hear about your work in Nigeria. Oh, and perfect timing as well. Well done. I'm now going to shift us to our next speaker so that we have some time at the end for our Q&A. Next up, we have Charles Muya. Mr. Muya is a seasoned program management professional with over 12 years of experience in community-based health and development programs. He currently serves as the programs manager at the Kenyan Network of Cancer Organizations, or KENCO. In this role, Charles leads the design and implementation of national cancer control initiatives, including advocacy, capacity building, and patient support programs. His work on cervical cancer includes developing and implementing cervical cancer programs, supporting prevention and awareness, strengthening and working with civil society and community health actors, and leading advocacy efforts to improve access to screening, treatment, and follow-up services. So I'll hand over to you, Mr. Muya.
So thank you so much, Ayla, and I would like to thank the CCA team for this opportunity. It was a good learning opportunity for us. So our project is focusing on informal settlements, and we are looking at promoting uptake of HPV vaccine in informal settlements in our capital city, Nairobi. And our public health problem is that HPV vaccine uptake is low. We are way below the WHO targets, and that is the situation that we want to change. Can go to the next slide. Next slide, please. So we identified a behavioral problem from the running series, and the problem is that the parents are not giving consent or taking their daughters for vaccination. And what we want to do is to educate and create awareness so that parents give consent or take their daughters for vaccination. So we are basically targeting parents or guardians of adolescent girls so that they're able to take their daughters for vaccination. Next slide. Yeah, so we were able to identify a number of barriers that are making parents and guardians not to take their daughters for vaccination. One of them is that they don't have information on HPV vaccine, and maybe even the information that they may be having is not factual. Then the other barrier that we identified is that community health promoters, and these were identified as the main sources of health information in the target community. So they do not provide information on HPV vaccine to parents or guardians. Then the other barrier is that parents do not trust the vaccine or are concerned towards, about its safety. We've had concerns from our target population on whether the HPV vaccine is a family planning method being introduced, and also concerns about its safety, especially after the COVID-19 period and the vaccination that followed. Then community opinion leaders also featured, and these are administration officers and religious leaders, and these do not provide information on HPV vaccine to the community members. Next slide. So we were able to develop a number of solutions for our intervention to change the situation. One of them is to equip community health promoters with information on HPV vaccine. And specifically, we want to train community health promoters on cervical cancer and HPV vaccine so that they're able to pass that information to their communities. And these community health promoters are part of a wider government community health strategy. So they are in existence, but they may not be trained on cervical cancer and HPV vaccine, and that is why they are not able to provide that information. Then we also plan to sensitize opinion leaders on HPV vaccine so that they're able to pass that same information to the community. Then provide job aids to community health promoters, including key messages cards on HPV vaccine, so that they're able to respond appropriately to questions that may come up from the community. Then another one is to organize community health promoters in teams and support feedback meetings for sharing of reports. And this is to encourage health communication, healthy competition among various community health promoters teams, and that would ensure that they are doing their work and being effective at that. Then we intend to integrate HPV into routine household visits, checklist by CHPs. So as I said, they are already there and they have some set of laws. But if you're able to integrate HPV into their routine work, then that would help us and it would help to ensure that they are passing information on HPV vaccine to the target community. Then we intend also to support community messaging, especially positively framed messages, allowed protection, and adding urgency prompts so that our target audience is able to take action. And this could be in form of IEC materials, social media campaigns, and use of trusted voices like cancer survivors. Then we also intend to write on existing community forums to provide information on HPV vaccine, then carry out mass awareness campaigns and do school-based outreaches. Next slide. So our key partners are, of course, Ministry of Health, and at the Ministry of Health, we have the National Cancer Control Program and the National Vaccines and Immunization Program. Then Nairobi County Health Government, the Health Department, now that health is devolved. Then Sub-County Health Services Team, health facilities in the target area, other organizations and programs working in the communities, and this is important for integration. Then schools in the target area for school-based vaccinations. Next slide. So some of the lessons that we've learned throughout the series is that parents, especially male heads of households, play a critical role in the uptake of HPV vaccination. So limited knowledge or misconception can create hesitancy, and that is why we are trying to address that. Then facility control suspicion came up strongly, like I mentioned, and we need to prioritize empowering parents with accurate information using behavioral science that we learned. Then CHPs are main sources of health information in the community, but they are not effectively giving information on HPV. So they need to be empowered to be able to do that. So they have a lot of potential in changing the narrative. Next slide. So next steps and what we are planning to do with the information that we've gained during the learning series. One is to integrate behavioral science in our cancer awareness work, not just on HPV. I think one of the things that we learned is that behavioral science can be applied to any public health problem. And as Kenko, now that we deal with cancer in general, we see a lot of opportunities and opportunities for employing behavioral science in our other cancer awareness work. Then we are going to be using lessons learned in program design and applications for funding. Then we are also going to sensitize our member organizations on key insights gained during the CCA series and how they can also use behavioral science in their work. Then CHP trainings and feedback meetings, as I've mentioned. Next slide. So these are our contact information, our website, Facebook page, X, and all that. So if you want to learn more or anything else, you can reach out to us. Thank you so much for the opportunity.
Thank you so
Back to
much,
you.
Yes, thank you so much, Mr. Moya, for telling us about your project in Kenya. We're sadly on to our last speaker of the day, so final chance to pop some questions in the chat for any of our speakers, or it might be a question for all of our speakers. But last but not least, I'm going to hand over to Priya Tiwari. Ms. Tiwari has an educational background in social work and counseling and has been associated with the Indian Cancer Society for a long time. She has experience in designing and implementing community-based projects focused on cancer awareness, education, and patient support. Her work connects public health education with community engagement to support sustainable outcomes. So over to you, Priya.
Thank you so much, Isala. First of all, thank you so much to whole CCAE team for giving me this opportunity to present my project in front of such a experienced people and who are working around the HPV. So my project name is Arogya Dhanush, Surakshit Ma or Betiya and Sajag Bharat, which means Health Shield, Safe Mothers and Daughters, a Healthy and Empowered Nation. Next slide, please. Yeah. So now I would like to talk to you first about the Indian public health problem. Health is a state subject and uneven priorities and implementation across state. And in India, we have a very large population and our progress in health is often slowed down by social issues, political challenges, and limited awareness. We have observed that most people do not prioritize preventive health care. They usually take action only after a disease appears. And because of this mindset, HPV vaccine uptake can remain low. To address this gap, we are focusing on children aged 9 to 14 years, as they are the primary target group for HPV vaccination and can also encourage their parents to get them vaccinated. By reaching them early, we aim to ensure that nothing comes between them and their right to a healthy future. Next slide, please. Yeah. So, because our target population is 9 to 14, so what is the behavioral issues and problems we are facing? The children between 9 to 14-year-old are not taking preventive actions, of course, because of the low awareness. Before demanding for the vaccination, they should make themselves aware what is the importance of the value. Only after that they can take initiative for the demand. Then the limited child and parent conversation around the health, around HPV. Parents are not aware, children are not aware. So there is no conversation between parent and children. Then low interest in preventive health. Parents are not very interested to initiate something which may occur in future. They don't want to take action before something will come in their life or on their body. Then who needs to act differently in this field? We, according to our target audience, we actually made the difference that children should ask their parents for the vaccination. We are making each and every child aware about the vaccination, about the importance, about the demand. So we are telling them that you have to demand for the vaccine from your parents because we are the people who will only make you aware. Then they have to keep following up even if delayed. Maybe their parents are busy that week, that whole month. Maybe they would say that we are visiting somewhere, we have some wedding, some event or something. But children has to keep asking that mother or father, you have told me that you will take me, so you have to take me for that. Then seek support from teacher, doctors, or trusted adults. If parent is not understanding the value of the vaccine, children can talk to their teacher, their elder one, or who understand the importance of vaccine, and they can help them to convince their parents to get them vaccinated. Next slide, please. Barriers. So the some barriers which we are facing because we are visiting Indian government schools to make children aware between the age group of 19 to 15. Some of them are even elder to that. So they do not know about what is HPV vaccine and why the vaccine is important. Even the teachers are not aware, even the school authorities, admin, nobody is aware about it. Children at this age often do not understand preventive health or long-term risk. Parents' background is same that they don't want to take initiative. Something is going to appear or something may affect my body after some certain age. I mean, they are not taking that initiative. They cannot get vaccinated on their own. They rely fully on parents to take the decision. Even if we are making them aware about the vaccine, they can't directly tell us that they are sure about the vaccine. They have to take permission from their parents, only then they can get the vaccine. Some children may feel scared of injections or misunderstand the purpose of the vaccine. Then discussion about the HPV, reproductive health, or sexual health may not be encouraged at home or schools, because we are facing this issue with the schools. When we are getting the permission from the principal, from the teacher, they are very particular about some words like sexual transmitted diseases or other words. You can't use those words in the schools. Then some children hesitate to bring up the topic or may feel their parents won't listen, because in India, people generally don't talk about the personal and medical related issues. Then many schools do not talk about HPV, making children unaware or unmotivated to ask. Maybe if somebody wants to know, from 15 children, only one child asked from their teacher that, ma'am, what is the HPV? She might say that don't ask me, or don't, she will not maybe motivate him or her to ask or know about that particular topic. Next slide, please. The solutions we are getting. As we know, each and every children are using smartphones. They are making themselves very, very aware. They are now making themselves very particular about some healthy habits. They are more aware about their body, and they are taking initiates. Like if I am not healthy, I'll start eating healthy, because that all the information is very easy to get nowadays. So now how we started, we are doing school-based outreach. We are taking sessions to be conducted for the class 6, 9 to build early knowledge and interest in HPV prevention. Even the last week we had a session of the class of 4th grade, and the children are more than between 9 to 13 age group, because there is a one school called MCD schools where the children of below poverty line are coming, and they have a elder age according to their standards. Then how we are doing it? So with the early and younger child, we narrated one story like child as a superhero, HPV vaccine as a protection shield, HPV as a supervillain. So they are really, this story is really helping them to remind the name of the vaccine and the virus. Then interactive learnings like health pledge, quick quizzes, and guided discussions to improve engagement and retention. And also, I haven't mentioned one program where we are working on it. We are making one small dolls with the title "I Vaccinated." This project is under construction. We are taking help from our cancer survivors and rehabilitation center. We are making small dolls, and as soon as we have a good amount of supply, we will take these dolls in our next session, and after the session we will give these dolls to children, which will give them one reward and motivation that the doll I have, it's vaccinated and she is protected. Now I will also get vaccination, and I'll protect myself and my future and my dream. Next slide, please. The key partner. Since schools generally allow only trusted partners to engage with students, and especially on the sensitive topics like HPV, and like other health-related issues, so the Indian Cancer Society partnered with Teach for India, an educational-focused organization already working closely with school kids. Next slide, please. The lessons we learned. The first lesson we learned, the target population is not always under your target. So like we targeted only 9 to 14-year-old, but our target populations are beyond that. We have to target the school principal, we have to target the teacher whom we have to ask for their lecture to talk to children. Our target population is even the school security guard, because we have to take the pass to enter in the school. So when we tell them that I am here to give the session about HPV vaccine, even he or she is not at all aware about this. So it's beyond our target audience. We are try to make people aware, whoever is coming in our way. Then the more things we learn, that high curiosity and motivation. Children are eager to learn about their health and want to protect themselves. Media driven learning schools. Schools, media, YouTube, films, and podcasts strongly influence how children understand diseases. For example, like wrong perception from screen media. Movies, web series often create false beliefs, such as cancer always being fatal or blood cancer being the most common. Because I ask students, which what do you think that which is the most common cancer in India? And every children mostly they said that blood cancer. Why? Because that easily shown in the movie. If blood is coming out from your mouth, you have a cancer. So that is one of the perception they made. And then awareness gap exists. Limited government-led HPV awareness vaccine campaign result unclear information for children and parents, creating a barrier to preventive action. There is no banner, there is no Anganwadi workers promoting. So there is nothing, any, a government-led awareness session projects are going on. Next slide, please. So yeah, so we have next plans that specific implementing behavioral science-based HPV and cervical cancer awareness across diverse stakeholder groups, which we learn through the series only, and measurables reach multi-sectors stakeholders like schools, families, educators, community leaders through integrated digital, academic, and media platforms. We have lots of other programs going on, so we are going to interrelate them. Like we have one mobile app, Rise Against Cancer app, radio outreach, Swayam e-learning course, which is on government platform, and faculty development program where we are teaching pan-India professors about the cancer. So we are going to use these methods and this learning with them. And then strengthening health-seeking behavior, HPV vaccination uptake and informed decision making, roll out even evaluate initiative within defined program cycle with annual impact review. Next slide, please. Yeah, this is from my side, and we are trying our best. And I wanted to thank whole CCAE team who really gave us the new creative mind how we can deliver these thoughts within our community and our target population. Thank you so much.
Thank you so much, Priya. That was an amazing presentation and great to see some of the really creative solutions coming through there to some behavioral barriers that I'm sure lots of people on this call have faced. So thank you for that. And to all of our speakers, yeah, it's great to see how you've applied the content from the learning series into your real world context. So thank you very much for sharing. We've got about 20 minutes now for a Q&A. So this is a chance to ask our speakers a couple of questions from their presentations. It looks like we've still got all of our speakers here, which is great. Also, if you think of any as we go through these questions, please do pop them in the chat. I'm going to start off with a couple that we have coming through. I'll start off with you, Gertrude, if that's okay. We've got a question here for you about your engagement with teachers as your target audience, which I'm sure is applicable in many of the contexts in which we are working on this call. Could you tell us about how teachers, as your audience, first reacted to your engagement with them around HPV vaccination? Maybe their hesitancy or eagerness to learn about HPV vaccination? Anything you can share with that kind of initial engagement with that target audience?
Thank you so much for that question. When we engaged the teachers, of course, they don't perceive health as part of their work. They were surprised that we are asking them such questions, whether they will talk about HPV vaccination. Of course, like, for example, the international school, they say we never even talk to parents. But explaining during these interactions, we explained the importance and they were eager to learn. I mean, they realized they have a role to play. They never thought they have any role. And interacting with them further, while trying to understand why. They was like, we are not confident. We don't know. we hear a lot of negative stories. We don't know whether it's effective. So the issues are about information, but they would be very much willing to be part of this campaign. Thank you so much.
Thank you for sharing, Ms. Nakituzi. I will now go on to I'll go on to you, Mr. Nifabutu. You had a very different target audience. I think you all did have different audiences for your projects. That's really great to see. You spoke a bit about training of traditional and religious leaders as vaccination advocates for HPV vaccination. How did you go about engaging those religious leaders? And did you experience any challenges with that engagement? Can you tell us a bit more about that?
Okay, it's just that most of these leaders, we realized from previous projects that they have a very strong impression on the people in their community. And being that we're in a religious part of the world, if you hear people saying that some of these vaccinations are sign of the beast, is them infusing in you this mark of 66. So I don't want to go to hellfire, I don't sell my soul to the devil. Someone will tell you that this is the way to reduce the population of the world. They will inject you and in no time you will just die. So if it's coming from their man of God or their religious leaders, they tend to believe more from these persons. And if the religious leaders are not aware, if they say don't take any vaccination, whether or not it is good for you, or as long as it's vaccination, they're infusing something into you, it's a no-no. No matter the kind of message you bring to them, they would not even want to listen to you the moment you just mention vaccine. And also the traditional leaders are the ones that head the communities, right? They are the ones that still come back to them, tell them about culture. So if culture says, because in this part of the world, many of us or many of them use herbal medicine. You hear them selling herbal medicine on the street, someone selling roots here, roots there. If you have, let's say, headache, you take this drink and that's all. If you have this, mix this powder with this and you're fine. And some of them will tell that it is God that gave them the medicine. So who are you to tell them a man made a vaccine for you and somebody saying God gave me a medicine that will heal me? So it's a lot from this other side. So we identify this as a challenge. And so that's why we're bringing them on board. And when we start talking about these things to some of them, because of some of their children are enlightened, right? They went to school. Some of them have traveled around the world. So you bring up some instances like that. And initially, they're like, especially maybe if you are dealing with, let's say, an imam, for example, and you're a Christian, somehow there's a bias to it. So have the Muslim members from our team go talk to them, meet them, and they're like, wow, this is from this light. Well, I don't know about this, and we can even bring them proofs online, get them videos of people that have gone through this pain and see how it can be prevented. So if you feel giving birth at home is the will of God making you strong, why do you risk the life of the woman? And they'll tell you that anything that happens is God's will, right? So by the time you start making it, these are preventable. It does not mean they are bad. It does not mean they are going against the law. You are just saving a life. And that's as simple as that. So it has really been an engaging session, hearing their own point of view and hearing from the community members and seeing the change in the acceptance. It's wow. So that's why it's our sustainability plan, so that even when we are not there, as long as they are enlightened, they keep putting it in their sermons once in a while. They keep talking about it in the mosques, in the church, in some religious programs. And then once I say my pastor said this and I tell somebody else, your pastor said this, are you sure? Me too, my mom said this. It just brings a very good acceptance rate for us. Thank you.
Brilliant. Thank you very much, Mr. Badu, for sharing those insights with us and those anecdotes. I'll move on to you next, Dr. Lawal. We have a question here about your the co-creation of IEC materials during your project. And for anyone who doesn't know what that acronym is, that's Information, Education, and Communication Materials. So you noted co-creating IEC materials for different parts of the country. There's a question here about whether this is something that you had done before, and if so, or if not, do you have any lessons learned to share with others on the call?
Yeah, thank you very much for that question. I mean, it's a great question. So, in terms of designing IEC, in particular for different locations in the country, we've not done that before. But one of the challenges with IEC from fieldwork is that they are not designed for particular population. They are usually one IEC for all the population. I've come to realize that the best IEC is one that is designed for the population which you want to educate, inform, and communicate to. One single IEC material is not usually effective for design it with healthcare providers such that it is culturally acceptable and also meets the needs of that locality, because we know that the healthcare providers in that community knows how best to communicate to them. So it's going to be co-design between us, the persons bringing the project, as well as those healthcare providers within the facility, so that we give what is tailored for that society. And we are hopeful and looking forward to how effective it's going to be. I think what you see that is used over the years.
Thank you very much, Dr. Lawal. I think you were breaking up a little bit there at the end, but I hope that we could all catch that and that response. I'll come to you next, Mr. Muya. We have two questions here for you. One of them is about how do you plan to choose opinion leaders to engage in the sensitization work that you mentioned as one of the solutions in your project. Could you speak a bit about that?
So thank you for the question. Yeah, so we are working with some specific communities in Nairobi, and we had first of all chosen two sub-counties so that we're able to narrow down to a geographical location that is manageable. And working with the Community Health Services Department, we will be able to map opinion leaders. Of course, when it comes to administration officers, we know them, and we know there are not so many, so we are able to target those in the chosen area. Then again, when it comes to religious leaders, again, working with the community health promoters, we're able to identify those ones to target. So I think narrowing down to a specific location to start with, and then expanding as we move on would be really helpful. But I think, like I said, we have identified a community. The informal settlements that we are talking about are quite a number in Nairobi, but we are not doing all of them at once. So we've identified some, and we've started some work with them. Yeah.
Thanks, Mr. Muya. I've got another question here for you. I know a few of the kind of presentations over the course of the Spotlight series have spoken about the engagement of engaging kind of boys and men in HPV vaccination advocacy. Could you share a bit more about your findings regarding the importance of engaging male heads of the household in HPV vaccination uptake?
Yeah, so thank you very much also for that question. So I think throughout this learning series, and maybe also to mention, we were also implementing a project funded by UICC in the same target location. And one of the things that we got is that parents are not consenting. And in some cases, the reports we were getting is that maybe it's the male head of the household that is not consenting. And that is why we thought it would be very important to involve both of them, because one of the questions that we were getting is what happens if the mother is consenting, but on the other hand, the father is not consenting. So I think it's very important to involve them. And what we were thinking of is maybe ways of how we are able to get to them, and one of them is through, for example, the religious organizations. And most of them have main groups, and we are able to engage them through such forums. The other one would be local community forums where men mostly participate, and that includes maybe administration meetings, maybe we call them barazas. The chief calls for a meeting, and most of the participants maybe are men, and that is one of also of the other forums that we are able to reach them. But it's very important for them also to be on board and to have the right information so that they're able to influence, because in most households, they're actually the key decision makers when it comes to health decisions. Yeah.
Thanks very much, Mr. Muya. And I've got a question here for you as well, Priya. It was great to hear about how you were kind of empowering children to protect themselves with knowledge about HPV and the vaccination. There's a question here for you about what kind of reactions were the children getting from their parents if they were kind of going back and maybe initiating conversations about this in their families and taking that information home.
So in India, we have another doubt is going on because when COVID-19 came, so after the vaccination of COVID-19, there are some certain myths around about it that there are so many side effects of it. People are getting cardiac arrest, other health issues. So now parents are relating the COVID vaccine with the HPV vaccine. They are saying like how we can trust about the same vaccine, how we are sure that it's not going to impact my child's health in future. You will give us the vaccine, but what about the future after maybe not 2 years, 5 year, 10 year, maybe after a good number of years, my child will get affected due to vaccination. Then whom will I contact or whom will I blame about the vaccine? So these kind of reactions we are getting, but there are some positive responses also because in some classes where 1% of children already got the vaccine. So children, I mean parents are getting motivated that okay, if a one child got the vaccine, that means it's a safe. And I'm giving my example because I got the vaccine when I was 24. I was also not aware about the vaccine earlier, so I got it. So I'm giving my own example that even I got it. There are other people who is in my contact in my organization working, they got it. And so there are negative and positive response, but as soon as we are delivering the concept of the vaccine in an easy way and in an interactive way, they are understanding the value of the vaccine and they are giving us the positive response about it.
Thank you. Super interesting to hear. Um, you also kind of mentioned a few really creative solutions to the kind of behavioral problem that you identified and obviously tailored to the audience, which was the children themselves. So things like your kind of age-appropriate storytelling, the use of dolls. How did you go about kind of developing those approaches and solutions? Where did those ideas come from?
So in this CCA series, my director is also here. So we both participated in the whole series, and we really liked the session based on the behavioral science and all that. So through that, we thought about first we thought about our target population. Then we also think about like how we can attract the children, because maybe we'll deliver the talk about the HPV vaccine, then maybe we will not meet them again, but how they can how they can just remember that information with themselves. So we wanted to give them one as a product like which can remind them again and again. And doll is something which is not easily disposable, they can keep that with themselves. They can maybe convert it into keychain, back keychain, or they can put it in their room or somewhere, so they can see whenever they are going to see that, they will get motivated, or they may just remind that somebody came in my school and talked about this, and this is something which is going to protect me in future. And also whenever students are coming for something else, like it's a normal school but there is some special session, they are expecting something uh, from them, like I'll get something in a hand, like maybe it's a pamphlet, it's icy material. And doll is something which always attract children or some kind of character. So that is the reason we created, and we are planning it. I mean, we got first we had one trial session with children from the age group of 12 or 14. So we were discussing about our project, like how would you react, how which kind of questions coming in your mind. So even uh, if we talk only about the vaccine and HPV, they were talking about more like tobacco, the vape, and smoking. So they are very curious. They have lots of curiosity to know about the cancer and the rule of the government, like how what government is doing, what the organization is doing. Like I see Indian Cancer Society, there are more organizations. We are getting lots of other organizations coming in my school talking about the hygiene, oral hygiene, and something. If this is something really important, why the government is not providing this vaccine free of cost in my school? So they have such kind of practical questions which we are trying to answering in a best way. But yeah, we are very sure that they are going to definitely like that dolls, because they are very interested to get that something which is showing them that I am protected and you will also. So yeah.
Brilliant. Thank you so much. We're coming to the end of our session, so I'll finish up with one more question, which I want to ask to all of our presenters today. So I'll go round each of you again. The question is, what would be one piece of advice that you would give to other CSOs who were working or starting to work in the HPV vaccination space? That could be one thing that you learned during the series that you think would be useful, or a piece of advice that you have from your own kind of work. I'll go around the circle, starting with you, Gertrude.
Thank you so much. I think one piece that I've learned personally, which I would advise others, is not to assume. Not to assume that people know, not to assume that health work know it all, not to assume that teachers know. We have to be deliberate. Whatever we do, we have to use behavioral science to understand the behavior of such audiences. Yeah, no assumption that they know. Otherwise, you need to take the behavioral science and understand what they know and what they don't know, so that they can do the work accordingly. That's my piece of advice. Thank you.
Agree, very important one. Over to you, Nifa, Putu.
Okay. One advice I would give is after knowing your audience, the way you pass your message matters a lot. Because if your audience are, for example, illiterate and you are coming from a professor standard, you will not pass information. You'll be there, you waste your time, and waste resources. So knowing your audience and also brainstorming on the best approach to pass the information in the simplest form, and also the people that influence their decisions. So I might talk to the mothers and they take orders from the husbands. It will not be effective. So know the people that influence their decision, know them, and also tailor the message to them so that you can have the maximum impact. Thank you.
Great. Dr. Lawal.
Yeah, thank you very much. So if I'm going to advise the CSO, I mean, CSOs do a lot of work based on passion. I think going forward, as I've learned from the series, is that there is science to everything. We should look at the science to whatever we do, not just passion. Uh, for advocacy, you should define your problem, the behavioral problem. You should diagnose to be sure that what you think is the problem is indeed a problem before you now design from brainstorming on the best approach to address the problem. Doing it that way, you'll be able to get a better outcome. Thank you.
Thanks, Dr. Lawal. I'll go to you, Mr. Muya.
So thank you. Mine is also somehow similar to the other speakers. And I would say always consult your target audience, know them better, seek to know them better. And once you identify the problem and potential solutions, always pilot before full-scale implementation. So always make sure that whatever you are doing with the population, first of all, is piloted with a small segment before you roll out fully, so that you know what is working in the target population before full-scale implementation. Thank you.
Great. Some great advice coming through here. And finally to you, Priya.
Uh, Thank you so much. So the advice I would like to give other CSOs that you might get distracted while talking about the HPV because people will say that there is not only HPV people are suffering, there are other diseases, there are other issues. I mean, this is what we are experiencing when we are talking about this HPV vaccine with the principal, with the school authority, with the government. Everybody is talking about the other problems, the other diseases, but we have to focus on our aim because we decided that going to work on this, so we have to keep in our mind that whatever our aim is, we have to first focus on it. We should not distract ourselves from other problems.
Great. And what a great one to end on. Keep your eye on the prize. Um, Brilliant. Well, a massive thank you to all of our speakers. I'll quickly wrap up to get you all out of here on time. Before we do wrap things up, please do take a few seconds to share your feedback on today's session. I think you'll have a poll popping up soon. And please do join us for our final session of the Spotlight series, which will be on February the 4th. Yeah, there we go. So you'll hear from 4 different cohort members. And remember, this session will be recorded. So thank you again to our speakers and the organizers of today's session and everyone who has joined us today. It's been a pleasure. And you should have your poll pop up there as well. So please do tell us what you thought.